Hi, I just wanted to provide a little bit of information on orthopedic surgery for some cases that you might see this week. So, when most people think of orthopedic surgery, they automatically think of bones, surgery on your bones. But surgical procedures that are concerned with bones, joints, ligaments, tendons, and muscles all make up orthopedic surgery. Some specialized equipment that you might see this week are this pegboard on the far left. And this is used when a patient needs to be placed in a lateral position, most often for a lateral approach hip replacement. We do these very infrequently, but we do have this pegboard. The patient is placed laterally, as you can see. Uh, this patient has a gel pad underneath him to kind of give him a little extra padding. That board is very hard. And then these pegs are placed in all of the little holes to position the patient appropriately. Another approach to hip replacement, which we'll talk about later, is an anterior approach where they go through the front of your hip. And this bed on the far right looks kind of like a torture device. It's not. This is a HANA table. And we use this for a lot of our anterior approach hips. We use it for hip fractures. So as you can see, the patient's feet are placed in these traction boots and then hooked to the leg spar, and then they can apply traction to the legs and hold them in place throughout the procedure. The most important thing to remember about the HANA table is that little post between the patient's legs. In this example, it's called a perineal post, and that post should be the very last thing removed. That post actually is what's giving that patient balance and support and holding them on the table. So if you move it and there's not adequate amount of staff to move and stabilize the patient, they could fall off the table very easily. The other important thing to remember with this table is to never raise and lower those leg spars when the patient's leg is in traction. Throughout the procedure, surgeons will have you manipulate the legs to provide them better control, better exposure to accomplish their surgical procedure. And it's always important to release the traction before you lower the leg and to always be communicating with the surgeon exactly what you're doing when they ask you to perform an action. This piece of equipment in the middle is Aquamantis, which is a bipolar sealer. So it generates energy for hemostatic sealing and coagulation of soft tissue and bone. They usually use it with like a saline, like a small bag of saline. Other specialized equipment you might see is a tourniquet, and over on the far right, that is what our tourniquet machine looks like. Basically, a cuff will be applied to the patient's leg, arm, extremity, and inflated. This reduces blood in the surgical field. Another thing you might see would be bone cement, and this is used in total knees, very rarely in like a total hip or something else. Mainly in a total knee replacement is where you would see it. The bone cement just helps to essentially glue that new knee replacement component into the patient's knee. Couple other things you'll see here on the far right. This is kind of another attachment to the bed. We do a lot of hip arthroscopies here. So this is a Smith & Nephew leg distractor. It will attach to the patient's legs much in the same way that the HANA bed would. And it just gives the surgeon good exposure to that hip joint for arthroscopy procedures. Speaking of arthroscopy procedures, this tower in the middle of your screen is an arthroscopy tower. There are many different components, but basically they control the in and outflow of saline through the patient's joint. There's also a machine below it that will be a shaver. So if a patient has any torn cartilage that needs to be removed or any sort of tissue that needs to be debrided out, they have specialized arthroscopy shavers that they can shave away that tissue, and that will hook into here. It can be controlled with a hand control or a foot pedal. You'll just need to know exactly what the surgeon's doing so you can provide them the right equipment. So some positioning considerations. Supine is for most of our orthopedic procedures, total knees, ORIFs. Most procedures are performed supine. However, we might do a lateral position for total hips, certain traumas, and the positions can vary widely based on if it's a trauma and you need exposure to a different location on the patient. Some common orthopedic procedures that you might see are total joint arthroplasty. We can do that in the knee, hip, shoulder, and even smaller joints. They can do finger arthroplasties, wrist, ankle, any joint can be replaced. Also an open reduction or internal fixation, commonly abbreviated as ORIF. This is essentially going in and putting plates and screws or some other fixation device to correct a fractured bone. Also arthroscopy procedures, which are small cameras, scopes inserted into a patient's joint for visualization. You can do it knee, shoulder, hip, like I said, anywhere. And an intertrochanteric hip nail. So this would be for a patient who has fractured their femur, which you can imagine is common in elderly and people who are prone to falls. This is probably a very highly performed procedure, hip nails. So our first procedure is a total hip arthroplasty, and in this procedure, first we'll talk a little bit about the hip. So as you can see off to the right, the hip joint is kind of illustrated there. So the hip is a ball and socket joint. The first hip surgery was actually performed in 1940, but the modern version of a total hip started to be performed around the 60s. There are over 450,000 hips replaced each year in the United States. Conditions that lead to hip replacements include osteoarthritis, which is the most common, where you just have that joint space narrowing, like you can see on the x-ray to the right. The one on the left, there's that little space in there for the joint, and on the right, you can see it's pretty much bone on bone. Rheumatoid arthritis, any sort of post-traumatic arthritis, which would be like the result of sports, motor vehicle accidents, falls, etc. Osteonecrosis, which is also known as avascular necrosis. So this is when there's an interruption of circulation to the femoral head, and the bone actually just starts to get necrosis. You can also have childhood hip disease, like a dysplasia, or some congenital diseases will cause hip problems and lead to hip replacement. So a patient would be a candidate for a total hip replacement when they start to have pain with activity, moderate pain at rest, any decreased range of motion, or pain not relieved by surgical intervention. The first step to treating a patient in most of the diseases that you'll see throughout this course is conservative management. So patients will go to physical therapy, patients will try to maybe have hip injections, for spine procedures, they'll have spine injections, etc. They'll do a lot of things to try to prevent surgery. Surgery is kind of a last resort. But if in this case the patient is still having pain and it's still interfering with their activity of daily life with the non-surgical interventions, then they will need to have surgery. As I previously mentioned, there are different approaches to performing a total hip. There's an anterior approach, posterior approach, and then they have a direct lateral approach. So the approach can be dictated by the surgeon preference, prior surgical incisions, or surgical procedures, patient factors such as obesity, dislocation risk, or even the implant selection of the surgeon. So in an anterior hip replacement, an anterior approach, the incision is made through the front of the leg. This is also known as muscle sparing. It is very popular. This is the most common way a hip is performed at North Kansas City Hospital because advantages to this are they have muscle sparing. It's believed to be less pain and a quicker recovery. Some of the disadvantages are there is a steep learning curve for the surgeon. SSI rates can be increased when you use this approach on obese patients. It does require that special HANA table, and the intraoperative fracture rate is higher with these patients. These procedures can often be done with a posterior approach in which an incision is made at the back of the hip. This is the most common for revision arthroplasties. It is still very popular for primaries. Some advantages are that it gives excellent exposure of the femur and acetabulum. A disadvantage is that dislocation rates post-operatively are a little bit higher. In a lateral approach, the incision is made on the side of the hip. So it splits your gluteus medius and vastus lateralis muscles. So that can be a disadvantage. It violates that abductor mechanism. It may lead to post-op limp. Some advantages, however, are there is a lower dislocation rate than a posterior approach. And like I said, this is dependent on the patient's anatomy, patient-specific factors, surgeon preference, surgeon training, the implant style. It's a variety of factors that go into this. No matter the approach, the basics of the procedure are the same. The damaged bone is first removed and replaced with prosthetic pieces. First, the femoral head is removed and replaced with the femoral stem that will go down into the femur. A metal or ceramic ball is used as a replacement for the femoral head. The damaged cartilage and bone are removed from the acetabulum and replaced with that acetabular component, sometimes just called a cup. And a plastic, ceramic, or metal spacer is placed between that femoral head and the acetabular component to act as the cartilage did before the hip joint was replaced. After the implant is placed, the incision will be closed with stitches that dissolve. The skin is most likely closed with a skin glue, occasionally can have staples, but the dressing will be applied and the patient will be moved to PACU. Occasionally they might place a drain, but this is not very common. Post-operative care for this patient would be early ambulation, not flexing their joint beyond 90 degrees as this can cause a dislocation. Implementations of DVT prevention measures, so that'd be, ambulation first of all, but they could potentially be on an anticoagulant. They will definitely have SCDs or foot pumps, most likely TED hose. Blood clots, as you remember, manifest through symptoms of pain in the lower extremity, tenderness, hot and reddened areas, edema, decreased pulses, cyanosis, or even venous distension. Other postoperative care would just be to monitor for those signs and symptoms of DVT or PE, provide pain management, and keep the legs abducted, avoiding adduction. You don't want to put them too close together. Occasionally on lateral hips, you'll see the patient will have an abduction pillow, which just kind of looks like a little triangle-shaped foam wedge placed between their legs to make sure that they don't adduct their legs too much. Complications from a total hip replacement can obviously include infection, neurovascular injury, DVTs, PEs, skin breakdown, bleeding, leg length discrepancy. So anytime they're taking out a whole part of the leg, essentially that top part is going to be just the component. So it's very important for the surgeons to ensure that the legs are the correct length again, because if they're not, that'll lead to, the patient kind of waddling, limping, and will cause further complications down the road. Patients can also dislocate their hips post-operatively, and the hardware can loosen. You can have implant wear. The hips aren't good forever. And then also the patient could reject the hardware. They could be allergic to the hardware, could get some sort of infection in there. The next procedure is a total knee arthroplasty. So this very similar to the hip, we're replacing the joint. We're doing the same thing in the knee. So conditions that lead a patient to have a total knee replacement or a total knee arthroplasty, sometimes you'll see it abbreviated like I did here as TKA, osteoarthritis, rheumatoid arthritis. In rheumatoid arthritis, what's happening is those synovial membranes become inflamed and thickened, which damages the cartilage, causes pain and stiffness for the patient. And then post-traumatic arthritis. It's very similar to the total hip replacement. Indications for a total knee replacement would be pain with activity, if patients have moderate pain at rest, any sort of decreased range of motion, any locking or catching with the knee when they're walking, and pain not relieved by surgical intervention. So they say really any time that the pain caused from any of these conditions is limiting the activities of daily living, hobbies, lifestyle, then they would potentially be a candidate for surgery. In a total knee replacement, the damaged ends of the femur and the tibia are removed. The femur and the tibia are sized to determine the correct size of the implant required. Metal components are then cemented into the tibia and femur, and this is where they would use that bone cement that I talked about earlier. The patella is then resurfaced and fitted with the plastic button, and a plastic spacer is inserted between the tibia and femur, creating a smooth gliding surface. So you can see that upper picture, the joint looks pretty damaged, pretty unhealthy. And on the right, these would be the components that are placed back into the knee. It doesn't show the patella component, but you get the idea of what's actually in the knee. And then that x-ray on the bottom, you can see between the femur and the tibia, there's very little space for anything. So that patient is pretty much, their bone is grinding on top of their bone, which would be pretty painful. Postoperative care for total knee replacements. Again, we want to promote early ambulation with a knee immobilizer. Weight bearing is permitted for these patients. They need to gradually begin light, low impact activities like walking or swimming. They will probably be in physical therapy, which will help with range of motion for them. Provide pain medications as ordered, and monitor for signs and symptoms of complications. And I do want to mention the physical therapy is also very important to keep that joint moving as much as they can. Some patients who don't move their joints really well are kind of slack off in physical therapy maybe, and also sometimes it's just genetics, but patients can develop like scar tissue and can develop stiffness in their joint, and then they can actually have to come in and have, they call it a manipulation. So the surgeon will actually bring them in, put them to sleep, and bend their knee for them and kind of pop all that scar tissue that's formed in there. So it's really important for patients to, make sure they're keeping up on their physical therapy. Complications from a total knee replacement can include infection, neurovascular injury, DVTs, PEs, skin breakdown, bleeding, and loosening of their hardware or implant wear. The next procedure to talk about is the ORIF, which is an open reduction internal fixation. So the open reduction component just means the surgeon is making an incision to realign the bone. So they're openly reducing the fracture. And then the internal fixation component is when they are holding the bones together with hardware on the inside. It is often urgent, but can be scheduled. Occasionally patients will break something and break an arm or a wrist, and the surgeons will wait for the swelling to go down before they go in and fix the broken bone. Occasionally in trauma situations, the patient might have more pressing injuries, but for the most part, these are done pretty immediately after the patient breaks their bone. So as you can see on the far left, that upper X-ray looks very bad. They broke their tibia. And then on the right, you can see how they've put a plate and screws, and the bone is aligned again. And you'll notice that the fibula is not fixed. It doesn't have anything going on, and it is very common. The surgeons usually 99% of the time would never do anything to the fibula, and that's just the tibia is what's giving the leg stability. So that's where they want to focus. And then you can see below in A, B, and C, just different views, different of them fixing a humerus fracture, kind of the same way, just plates and screws. On the right, you can kind of see how this procedure is performed. They're doing an ankle here, so an incision is made in the lateral aspect of the ankle. The fracture is identified. They kind of clean out any loose debris. They reduce the fracture by using these like bone clamps up there to put the fracture back together. Put a screw in to keep it together. Then they'll put this plate. They have different size hole plates. So if it's a kind of a small fracture, they have 3, 4 hole plates. They go up 8 hole plates, 10 hole plates. They have a lot of plates. And then the screws are placed in the plates to hold the bone in its correct position. And after that's done, they will close the patient up. A lot of times these implants will be left in the patient if they're getting loose, if they're causing pain later down the road, they will be removed. Postoperative care for patients who have an ORIF. For lower extremities, they usually need crutches or a walker because most often they are non-weight bearing for about 6 weeks. They can use passive range of motion, and they will still go to physical therapy because you don't want that joint to, freeze up completely. For upper extremities, they might need a sling or support for the first 2 to 4 weeks. Again, they will attend PT and perform passive range of motion activities, and they can resume light activities in about 6 weeks. Complications from ORF procedures can include chronic pain, malalignment of the fracture, non-union, so the fracture might not heal back together. You can have rejection or loosening of the hardware, infection, stiffness or immobility, DVTs or PEs, skin breakdown, and bleeding. The next procedure I want to talk about is an arthroscopy. So this is where a small incision, sometimes called a keyhole incision, is created and the camera and instruments are inserted into the patient's joint space. Indications for an arthroscopy would be to repair or remove damaged structures or to confirm a clinical diagnosis. That's not as common. It's mostly to repair or remove damaged structures. So this would be if a patient has a tear in their cartilage, if they have something kind of going on in that joint space. It's a generalized approach, but you can do this, like I said earlier, in a variety of locations. Shoulder, knee, hip, really any joint that you have. Sometimes they do like wrist arthroscopy, or you can do smaller joints as well. Here's a great video of a shoulder arthroscopy. It is about 14 minutes long, a little long. I did put the link in under the procedure, under this presentation link in Unit 3. So if you want to see a shoulder arthroscopy, I think it's a great video to watch. Postoperative care for these patients depend on the surgical site. They might need crutches, a sling, or an immobilizer, depending on the location. Ice is great. They most often use a little bit of cold therapy on all these patients, and then they will attend physical therapy. Complications can include infection, nerve damage, DVTs, PEs, and immobility or stiffness. So the last procedure I want to talk about is an intertrochanteric hip nail. And so this is performed anytime that the hip is fractured. So as you can see on the far right, there are different areas of the hip. So they will classify the fracture based on where the fracture happens. So if the fracture happens in the femoral head, they'll say it's a femoral head fracture. Femoral neck would be a femoral neck fracture. This intertrochanteric area, they would say it's an intertrochanteric hip fracture, or below it a subtrochanteric would be obviously a subtrochanteric hip fracture. Sometimes we'll just say a distal femur fracture. Based on where the femur is fractured will determine what type of procedure the patient will have. If the fracture is too high and it can't be fixed, patient might have to undergo a total hip, or they have a hemi-hip where they replace just a couple of the components. If it's lower on the femur, they might get just a plate and screws. If it's a little bit higher, they could end up having a hip nail like we're going to talk about. So it's all really just dependent on where the fracture occurs. So this is the hip nail procedure. Essentially, they will do it very similar to an ORIF. So they'll go in, they will put the bone back together, try to align it. Then they will put in plates and screws, and usually this really big screw up into the femoral head. So you can see kind of what it looks like on the left, and then the right pictures are the x-ray of that happening. So they can do it on the left where you would have this ORIF of the hip, or on the right what you're actually seeing is that hip nail down in the femur. Postoperative care for these patients includes early ambulation with crutches or a walker, ice or pain relief, and they can be weight bearing dependent on the surgeon. I also have linked a video to a hip nail that I think it really kind of goes through the procedure very well, better than I could do, and so that is also linked in the Unit 3. Complications from this hip nail can include non-union, so the bone might not form back together again. Infection or hardware rejection can happen. The patient can develop a DVT or a PE, immobility, and nerve damage. So, and something else that I want to mention real quick about femur fractures, one giant complication from femur fractures across the board is like a fat embolus can occur very readily, and this is where a piece of fat, usually like from the bone, gets dislodged and enters into the patient's, vascular system and can cause a PE, and it can be very sudden and very scary, and the patient can, ultimately suffer extreme consequences up to and including death. So this is something to be very cognizant of in these patients that have femur fractures. This is a high risk for those patients. Okay, there's a few references if you want to check out a little bit more information. Thank you for listening, and I hope you enjoy your week in orthopedics.